see us live somewhere, and I think we are live.
And are we, like Kemal, last time you were asking me some questions at the end. Are you going to do it again?
We are live, Dr.
Okay, all right.
All right. So I'm just watching from our other side. So then, okay, so, right. So we are going to go ahead and start. Good evening. Today is December 9th, Wednesday night at 7 p.m. We are with you. This is United Medical Wellness Program, our diabetes program. We have our regular program topics that we are going to cover, and then we do have a guest. So before I go too far with this, I'm going to actually share my screen, and then I'll open my PowerPoint. And so from our side, Donna, I'm going to need your okay from you, so then everything looks okay from there. So
yes, it does.
Yeah. So my name is again Kemal Erkan. I'm the chairman of United Medical ACO. I have Donna with me, director of clinical integration, and Dr. Hundal, Amy Wilkerson, and we do have a guest, and I'm going to have Amy to introduce her. Amy, if you would like to take over from here.
So welcome to our Wednesday Wellness with Diabetes, our diabetes program. So twice a month, although once this month in December, because of the holidays, we talk about diabetes. So all the different aspects of diabetes, your heart, your kidneys, your feet, your eyes. And today we are lucky enough to talk about two important topics. Dr. Hundal is going to talk first about all of the different types of diabetes medicines. There's a lot out there. And I know I always get a lot of questions. Well, my doctor started giving this new medicine, and what's it going to do to me, and how does it work, and should I take it? Like, well, if they said you should take it, you should take it. So he's going to explain about that. And then we have Celeste Milliner, a diabetes nurse and diabetes educator, who's going to talk about oh, and look, oh, good. Thank you. There we have, our panelists. Celeste is going to talk about continuous glucose monitors. So how they work and different technology with diabetes. So how they work, how they benefit people. And we get a lot of questions about that. So I'm excited to welcome both of them for this very important information. And as you all know, it's on our website, or it will be, right? Come off, so available to go back if you have more questions. And I will turn it over to Dr. Hundal.
So what I'll do is I'll make you the co-host. Actually, I'm going to give you access. Let's try. I'm going to give you access my remote mouse and see if you are able to. If it doesn't work out, I'll take it over. But so I'm not going to touch it, so it's all yours.
Okay.
Okay, that's
How do you? I'm just trying to go back.
And just right click and yeah, there it is.
Okay. All right. Okay. Good evening, everyone. I'm Ripu Hundal, one of the endocrinologists in Delaware, working here for the last 20 years. So currently, I'm working at the First State Endocrinology in Newark, Delaware, and we have one other location in Middletown, Delaware. So I was asked to present and talk about outpatient management of diabetes. As you know, diabetes is growing at an epidemic proportions. There are around 30 million US people with diabetes. Majority of them, 90% of them, have type 2 diabetes, and 10% they are type 1. So a lot of people first say, okay, type 1, type 2. I'll just briefly explain. Type 2 diabetes, which is majority chunk of the patients, that's related to insulin resistance. Body is making insulin, but not sufficient. And the organs in the body are resistant to the action of the insulin. So they need more and more insulin production to overcome the resistance. So typically in these patients, we use medications along with insulin later part of their disease process. Type 1 patients are individuals who, because for some reason, either autoimmune reason where body starts making antibodies and starts attacking their own organs. So the antibodies attack the islet cells and results in decreased secretion of insulin, or almost virtually none. So they are insulin dependent throughout their life. They have to stay on insulin. So it's important to differentiate between type 2 and type 1. Type 1 typically seen in kids and teenagers, young people, but it can also present later part of the life in thin-built individuals who may present with sudden onset of diabetes. These are called latent onset autoimmune disease of adults, or LADA. So they behave like type 1, but they present maybe in 50s, 60s. I had some patients presenting in 70s, 80s, and over there, they are insulin deficient. So we have to use insulin in those individuals. So diabetes is a very, very complex disease process. It's not just one organ. Like in people with type 1 diabetes, mostly they lack insulin. Their pancreatic islet cells are not making sufficient insulin. Type 2 is more complex. So here I'm going to go through these slides. Let me see, I think the original color format has changed. It's not showing up properly. Yes, the fonts, the colors are different. So everything is messed up here, but I'll just try to explain. I mean, these things at the back, the color, it's becoming white. So it just, you can't read them properly. So in patients with diabetes, type 2 diabetes, their multiple organs are defective at the level of the pancreas. They are not making sufficient amount of insulin. Then also there is another hormone called glucagon, which is a counter-regulatory hormone, helps the body to raise the blood sugar. The glucagon is inappropriately elevated when they should be down. When we are eating too much, body has sufficient carbohydrates, glucagon levels should be suppressed. But in people with diabetes, the glucagon secretion is elevated and insulin secretion is down. Then at the level of the gut, there are some of these hormones which help the body to make more insulin immediately after we start eating. These are called incretins. So in patients with diabetes, these hormones called glucagon-like peptide 1, glucagon-like peptide 1, they are not made in sufficient quantity, or there is some degree of resistance as well. And then obviously people with diabetes.
Hundal, I'm so sorry to interrupt. If you would like, I have your other presentation available. This one, I think when they copy paste to our format, it lost the color. I can see that. Would you like me to just put? If you just
if you can, that will be better.
It's gonna be. It should be very quick. So if you give me a second. I was able to locate it from the other side, so it will be 2 seconds for me to pull that up. I can see that's the colors are all different, so and I think that's just unintentional. So here is 825. This is it.
Isn't that the old one?
Should be 2 of them.
Is this it?
I don't think, I think that's the first one we did that doesn't address all the medication,
This is the
right?
8. I mean, there should be 2 of them. Like, just go to the next slide, see what is the most recent one. The first one was.
I don't know if Kemal has the most recent one.
Oh, so there's a different one. So this is the other
one. Yeah.
Just go to the second. Yeah, no, not this one. This is. Yeah, this is one with the COVID, we talked about the COVID. That's the one.
Okay, so those are the two I have, guys. Sorry.
All right. So I guess we'll keep talking.
All right, so the panel controls on you again.
Okay. All right. So to continue with the discussion, at the level of the gut, there are also, people tend to eat more, so more carbohydrates, sugar is coming to raise the blood sugars in the bloodstream. At the level of the liver is very active and making too much of glucose. So that also contributes to high blood sugars in the blood. At the level of the kidneys, usually this is how we get rid of extra glucose out of the body. And in people with diabetes, they tend to reabsorb this glucose back into the system. So that also contributes to high blood sugars. Then in the fat cells and in the muscles, they are more insulin resistant. So typically fat should go inside the fat cells. But in these individuals, because of the insulin resistance, more fat is released into the bloodstream. So free fatty acids impair the action of the insulin, which also contributes to decreased glucose going into the muscles. So actually more of the glucose stays in the bloodstream. So all of these things leads to ultimately high blood sugars. And then there is a defective brain innervation with the nervous system, which prepares the body for adequate insulin release that is also defective. So treating diabetes just by one drug is going to fail because, as I explained to you, there are multiple organs are affected. So if you use different drugs working at different areas, then you will get the best results. So here, these are the classes of medications. There are a lot of them. I mean, we will discuss about them later on. These are called the GLP-1 agonist, working for the glucagon-like peptide 1 hormone, which I explained earlier. Then there are drugs which works on the pancreas to make more insulin, certain drugs working in the brain. Then these are called the thiazolidinediones, working on the muscles and the fat cells to improve insulin sensitivity. Metformin works in the liver and helps to decrease the glucose production by the liver. And then these are new class of medication called the SGLT2 inhibitors, which helps to get rid of extra glucose in the urine. So this is the algorithm given by American Diabetes Association. This is new way of treatment of diabetes. So first, whenever patient is diagnosed with diabetes, obviously we look at their hemoglobin A1C. If it's above goal, then we say, okay, we need to start you on some medication. So first of all, we look at is if they have underlying heart disease or chronic kidney disease. If they have these things, and in one individual, if they have more of heart problems, now the American Diabetes Association is recommended that we should use these GLP-1 receptor agonist with a proven cardiovascular benefit. And they can be combined with another class of medication called the SGLT2 inhibitors, which helps to get rid of extra glucose in the urine. Second class of patients, if they have more prominent heart failure or chronic kidney disease, then the SGLT2 inhibitors with evidence for reducing heart failure and improving the chronic kidney disease should be used in those individuals. So this is important to understand that baseline, like as in the first, metformin is the oldest medication. So it's cheap, it's generic, it's been out for 20, 25 years, does not cause major problems. So still metformin is considered first line medication along with diet and exercise. But then you go down this pathway, depending upon what the person has, then you pick the medication which is best for that individual. If you go this pathway, if the patient does not have underlying heart disease or chronic kidney disease, then we can decide which drug to use. For example, if some elderly individuals, we are concerned about low blood sugars. So obviously we don't want to use medication which can cause low blood sugars. So here are different classes of medication that your doctor can talk to you and decide, okay, maybe this is better regimen than as compared to other medication which can cause low blood sugars. If in individuals we need to lose more weight, which is in majority of the patients, then these SGLT1 agonist and the SGLT2 inhibitors are good drugs to use. And in the third one, where cost is a factor, where we can't use expensive medication, then these older medication called sulfonylureas and thiazolidine diones, they can be used. So you have to discuss with your doctor who is treating you and then decide which way will be the best way. So I will just quickly go over different classes of medication so you can understand better if you are on these medication, like how they work. So these are the sulfonylureas, which basically works by increasing insulin secretion. So they are glybride, glipizide, glimepiride. These are available on the market. They increase the insulin production. The main problem with this is the hypoglycemia. So if you take the pill and then skip your lunch or dinner, the medication is still going to work, and there is risk for low blood sugars, and people can pass out from there. When you get more low blood sugars, what we do? We eat more. So these medications are associated with weight gain. So these are important things to consider. So nowadays, these drugs, classes of drugs, we usually keep it on the side. These are mostly if patient has cost issue, we will use it, but there are other better medications. And especially in people with chronic kidney disease, they tend to have more problems with low blood sugars. One thing is the glybride is the oldest medication that is very long half-life, and that is the most culprit in causing low blood sugar reaction. So in older individuals, in patients with chronic kidney disease, probably better to use glipizide and glimepiride rather than glybride. Second class of medication, that's meclidinides. These are marketed as Brandon or Starlix. If you have used these drugs, these are the generic neteglinide and repeglinide. These are quicker acting medication, leads to rapid release of insulin release, and it is not long acting as compared to the first class of medication. But still, side effect is hypoglycemia and weight gain. So this is a quick action, and then it's out of the body. Then the bioagonists, that's the metformin. That's the most commonly used drug. It decreases the insulin, hepatic glucose production, so works on the liver. The main side effect is diarrhea, nausea, some degree of weight loss. So it's important to understand that this drug is very safe. It can be used in people even with chronic kidney disease, as long as the GFR, that's the kidney function test, is above 30. So, but below 30, it should be avoided, as it can lead to what is a rare condition called lactic acidosis, which can be lethal. So you have to be careful, follow the kidney function test on a regular basis. But by itself, it does not cause it does not cause kidney damage, and it does not cause any low blood sugars. The next class of medication, pioglitazone or rosiglitazone. These are the two drugs. Rosiglitazone is no longer used because of some controversy. So still pioglitazone is available in the market. Mostly it's insulin sensitizer at the level of muscles and fat cells. So it nicely lowers the blood sugars without causing low blood sugar reactions. The main side effects is with swelling, weight gain, anemia, which is very minor, but more important is also can cause congestive heart failure, especially at higher doses, and some degree of bone loss. So you have to weigh the benefits and the risks involved while using these medications. Then these are called alpha glucosidase inhibitors. These are acarbose, miglitol. They work to slow down the breakdown of carbohydrates in the stomach. So this medication is taken only with meal. If you are not eating, you do not take this pill. So if you are eating high carbohydrates, sometimes eating too much, then can pop 1 or 2 tablets with it. That helps to decrease after meal blood sugars. The main side effect is flatulence. That's why this drug is not commonly used. At higher doses, it causes stomach problems. And then anybody with higher kidney function test, it should be avoided. Then these are called DPP-4 inhibitors. This is marketed as Januvia, Onglyza, Tradjenta, Nesina. They are not generic. They are all brand names. They basically work on the hormone called the GLP-1 and prolong its effect. So it helps to lower the blood sugars. They're relatively safer drugs, does not have main side effects. Some people may complain of some stomach problems, very rare risk of pancreatitis. So if anybody has history of pancreatitis, they should not be on this medication. And these medications are usually used based on the GFR. The dose can be reduced. It can be even used in patients on dialysis. So that's one good thing about these medications. So every drug has a different dose based on the GFR, except the last one, the linagliptin Tradjenta, 5 milligram daily, that's used irrespective of the renal functions. Then these are the GLP-1 agonists. You must have heard a lot of ads on the TV nowadays, once weekly, Ozempic, Trulicity. So these are drugs which are given by injection, but they're not insulin. They help the body to make more insulin, help to suppress the appetite, help to slow the stomach emptying. So all these things leads to improvement in the blood sugars. But since it also suppresses appetite, there is more weight loss associated with this medication. So some of these drugs are given twice a day, once a week. And then there is the last one called Rybelsus, is now an oral tablet as well. So these mostly works by improving the blood sugars, fasting, as well as after meals. The main side effects, again, stomach side effects, nausea, vomiting, rare risk of pancreatitis. And then if somebody has history of medullary thyroid cancer in the family or personal history, they should not be on these medications. So again, these drugs are used based on the GFR. You have to discuss this with the family physician whoever is treating you to make sure you are on the right dose of the medication. But again, they can be used in people with advanced renal insufficiency as well. Then there are SGLT2 inhibitors. These are another class of medication which down the line you will be seeing more and more of its use in patients with heart problems, with congestive heart failure, with a chronic kidney disease. So the cardiologist, nephrologist, endocrinologist, family physician, they'll be using this class of medication more and more down the line. So as I explained earlier, these classes of drugs, this class of drugs, they mostly work on the kidneys and help to get rid of extra glucose in the urine. So along with glucose, it pulls out more water as well and salt. So people can pass more than 400, 500 ml of urine extra. So it works as a diuretic as well. So these drugs are given by mouth only. The main side effects is that it can cause genital fungal infection because it makes people pass more glucose in the urine. So just maintaining proper personal hygiene avoids that problem. This condition is not that common. And then very, very rare risk of diabetic ketoacidosis, where if some person develops consistent nausea, vomiting, severe belly pain, they should immediately stop the medication and seek medical help. There was some earlier concern of lower extremity amputation with one of the drug in Invokana, but recent studies have shown that that may not be true. So these class of drugs are really good drugs to use. They cause 4 to 5 millimeter drop in blood pressure, 5 to 10 pounds weight loss, along with lowering the blood sugars. So then again, based on the GFR, kidney function test, the dose has to be cut down. So can be used in different ways. Now talking about the insulins, as I told you earlier, people with type 2 diabetes, first we initiate all these oral medications. Time will come because of the progressive nature of the disease that they may require insulin. So there are different insulins available on the market. These are all human insulin. or they're analogs, so it's no longer made from animal insulins. So this is the older one. NPH insulin is a cloudy insulin. Then there are insulin analogs, which are much, much better. These are like glargine or Lentus, if you have heard about that. This Detamir is the Levemir insulin. Degludec is the Tresiba insulin. These are all long-acting insulin. Then there are short-acting insulin, like the Humalog, Novolog. You must have heard about that. Epidra. Then there's a faster-acting insulin called the Fiasp. Works better, faster than the other insulins. And then there are mixed combination insulin like 70-30, 75-25 insulin. So they come in all different ways. The one thing is about these older insulin, especially the regular human insulin, it doesn't work that fast. So it has to be injected half hour before the start of the meal, versus fast-acting insulin are injected closer to the meal. So this is different way of showing rapid-acting insulin. This is the short-acting insulin, regular insulin. Then this is the NPH insulin, has a peak, and then it goes down. And then these are longer-acting insulin called the Degludec, Glargine insulin, Levemir insulin. I already explained about the differences in terms of their peak effect. So again, depending on which insulin you are using, you have to be careful with using that insulin. The next one is the inhaled insulin that just came on the market. Actually, it has been out there for a long period of time. Then there was problem with the companies, and now it is the mankind. They are now back on the market. So this insulin, the rapid, has a very rapid absorption. This is the inhaled insulin called the Afrezza. So it's just you take a puff when you're ready to eat. It quickly works, and then it's out of the system. Unlike the other insulin here, it's written that the rapid-acting Humalog analogs, it has more prolonged action and more risk for hypoglycemia later on. So this is another Afrezza. If people who do not smoke, who do not have lung problems, can use this type of insulin. And then we have the pumps available. So this is used for both type 1 and type 2 patients, where the fast-acting insulin can be put in the pump, and that will help to, it's going off its own. So they can be educated about the pump delivery. It's a very optimal way of delivery of the insulin, much more effective than the injections. But again, patients should be motivated to be able to change the pump settings, be careful about the carbohydrate intake. So this is another very good way of improving diabetes if they're still having problems with taking multiple daily injections. And now we have glucose sensors available along with the pump. They are trying to make an artificial pancreas where the glucose readings are relayed to the pump, and pump determines how much insulin to be delivered, the basal insulin. And down the line, they're working on algorithms where, based on your blood sugars going higher after meals, the pump will keep on delivering more insulin to keep the blood sugars in a better control. So basically, the pump will be handling everything down the line. So this is a novel way of treating diabetes, and things are getting better and better in keeping the blood sugars in a better range. So I will stop over here now. Thank you very much.
Thank you, Dr. Hundal.
Thank you.
So we're going to turn things over. Thank you, Dr. Hundal. We're going to turn things over to Celeste. So Dr. Hundal ended us on a good note with pumps as we do further review of technology. And Celeste, who's going to control the, Kemal, who's in control over here?
I am.
Kemal, are you going to do it?
Yeah.
Okay, great. Thank you.
So we don't have a lot of them anyway, so I'll do it. Go ahead.
Okay. So my name is Celeste Milliner, and I have been a nurse for about 30 years. 15 of those were focused on diabetes. So today I was asked to share some information with you regarding glucometers, continuous glucose monitors, patch delivery insulin devices, as well as insulin pumps. So next slide, please. So, here is just a quick snapshot of some examples of glucometers. And I wanted to kind of provide a little bit of background for you all. Home glucometers have only been available since about 1981. So, when you think about it, it's fairly new technology. There are probably somewhere in the ballpark of 40 to 50 different types of glucometers available. And as far as options go, or making a selection, my advice to you is really to discuss with your healthcare provider which meter your insurance will cover. They all work relatively similarly. So it's a very small drop of blood that's placed just from the side of your finger onto a test strip. And then you'll get a reading within just a few seconds. So, it's nice to just have a collaboration with your healthcare provider. There are certainly advantages of some over the other, but none that are significant enough that would, make you go astray from what your insurance is covering. Next slide, please. So self-monitoring essentials. So a couple of things I wanted to highlight here. Please follow your healthcare provider's recommendations with regards to how often you test, what the guidance is for where they want your low number to be, as well as your high number to be. And if you do experience lows or highs, how to treat those. Another point that I wanted to highlight is expiration dates. So many people believe that expiration dates are kind of a little bit phooey with some medications, if you will, but when it comes to diabetes supplies, with test strips, with insulin, and with diabetes medications, you always want to be certain that your prescriptions are not expired. There are two things that will cause test strips to work erroneously or to not be accurate. And those two things include light and moisture. So always keep your test strips sealed in the container and avoid light and excess moisture for the best results. Additionally, if you ever get a number that just does not make sense, always wash your hands, dry them well, and repeat the test before you treat accordingly. So as far as the techniques go, it's best to have clean hands. And by that, I mean soap and water when at all possible. Things such as antibacterial hand soap, lotions, toothpaste, they can all have an impact on your reading on a home glucometer and cause that number to be inaccurate. So try very diligently to have clean hands. If you use warm soap and water, you'll get a better drop of blood. So always try to do that when it's convenient for you. So where, how, and why to perform the procedure? Like I mentioned, you want to stick the sides of your fingers. The ends of your fingers actually have a little more nerve endings. So, try to avoid that and go with the sides. Some meters will also talk to you about alternate site testing, where you can use perhaps the palms of your hands or your arms. And that's fine for routine management. But if you are symptomatic of a low or high blood sugar, you must always go with your fingertips for your readings. The readings that you will get on alternate sites are not as accurate as that when you're testing the blood in your fingertips. So next slide. So collaboration with your team. If you get nothing else out of what I say today, this is really, really essential to your overall diabetes management. So why? Why is this important? It's very important because your healthcare provider needs to know how you're managing this at home. Are you checking your blood sugars? What types and what amounts of food are you eating? What time of day? And how much medication are you actually using? Without this information, it's very, very difficult for your healthcare providers to make accurate and appropriate treatment adjustments. So work with your team. You are a team with your healthcare provider. You are your greatest advocate. So the more information you can provide them at the time of your visit, the more meaningful your visit will be. So let's move on to continuous glucose monitors. So continuous glucose monitors have been out for about 15 or 16 years now. As an overview, they are placed on your skin. There is typically a little sensor that goes through your skin, and there's a chemical reaction that occurs where it will give you continuous glucose readings about every 5 minutes. These devices are typically worn on average somewhere around a week, sometimes 10 days, sometimes 14. And there is another option that can be placed and worn a little bit longer. But overall, the benefits of the use of a continuous glucose monitoring system include alarms. So initially, many patients or many providers really focus on the benefits of, goodness, Sally doesn't recognize when she's going low. She's having lows in the middle of the night while she sleeps. Having those alarms notify her without her trying to stick her finger can be a huge benefit and a huge safety tool in your bag, if you will. So the alarms are very, very, very essential in managing your diabetes, particularly if you don't recognize highs or lows. They're also really great to see how exercise impacts you. So, you know, in Dr. Hundal's discussion, he was talking about the benefits of exercise. To really see that on a graph where you can see that when you exercise, your glucose levels are actually much lower, and that effect can take place for up to 36 hours after your exercise. Using a continuous glucose monitor will help you modify your medications when you are exercising, and this will help to keep you safe and also help you lose weight. The trend arrows are probably what I consider to be the biggest benefit of having a continuous glucose monitor. So you'll have a number, you'll have an arrow which will show you what direction your blood sugar is going. Are you rising or are you falling? And then you have the alarm. So those are all the benefits. But those trend arrows, if you think about it, if you're checking your blood sugar, let's say 6 times a day, and you know, I'm getting ready to get behind the wheel of my car and my blood sugar is 80. Well, I'm doing a happy dance. 80 is really fantastic. But if I have access to a continuous glucose monitor and I see that, yes, my blood sugar is 80, but it's dropping like a rock, well, I'm probably not going to want to get behind the wheel of my car without having a treatment for that pending low before I get behind the wheel. I hope that makes sense. Those trend arrows really help you not only see where you are right now, but where you are going within the next few minutes. And those are very, very beneficial in managing your diabetes. So options that are currently available with regards to continuous glucose monitors, as I had mentioned previously, they all work fairly similarly. If you look at the top left-hand corner, that's the Dexcom. Most of these devices include 3 essential parts. One is a sensor that will go into your skin. One is a transmitter that will connect to the sensor and then transmit, if you will, that number and that data over to a receiver. And then the receiver piece can sometimes be a separate device or even a cell phone. So the top device is the Dexcom that I had mentioned. The top right-hand corner is a newer one on the market. If you look on the bottom left of that slide, you can see there's a small image. That is a device that's actually placed underneath your skin. It does require a procedure to have it placed as well as removed. And that device is supposed to be good for up to about 90 days. The bottom left-hand corner is the Freestyle Libre. And if you look at that, it's got the black receiver, if you will, and then another device that's about the size of a quarter. And that device is the most cost-effective continuous glucose monitor that's available at this time. If you look at all of these screens, you can see where it does display the number, the directional arrows, as well as they will all alarm. And then on the bottom right-hand corner of your screen is the Medtronic sensor. So they all work very, very similarly. And if you notice in these pictures, some of these devices actually have the ability to be integrated with an insulin pump. And Dr. Hundal discussed some of the benefits of insulin pump therapy with you. They can be used in conjunction with insulin pump therapy or alone without insulin pump therapy. But they are probably the greatest benefit to managing your diabetes, particularly if you are on mealtime insulin. And, you know, again, I'm going to throw out the caveat. Please discuss these options with your healthcare provider, and they can review what system is best for you. This is kind of in a little bit of a class of its own. It's a patch delivery pump. So Dr. Hundal had mentioned the benefits of insulin pump therapy. This device on your screen right now is called the Vigo. Some benefits of that are that you know, it's one stick, and it does provide a little bit of that continuous insulin to cover the sugar your liver is producing. But you also have the ability to hit a small button to give doses in increments of 2 units at a time. So it's nice if it's definitely less expensive than than an insulin pump. It is convenient in that you don't have to give yourself those mealtime injections while you are wearing this. So there are a lot of benefits to using this device. Some limitations are that you're set at 2 units. So each time you hit that button, you definitely will get 2 units. Now you can push it multiple times depending on your insulin needs, but that is a limitation that you cannot precisely deliver with this device a very small or precise dose of insulin. So on to insulin pump therapy. So Dr. Hundal did a great job highlighting some of the pros. It's the closest thing to truly mimicking the action of the pancreas. Very precise delivery, as I had mentioned, and they can be discreet. You don't have to pull out a pen or a syringe to administer a dose of insulin while you're out to dinner. Cons for insulin pump therapy is that it does require work. And I think Dr. Hundal alluded to this. It's not a quick fix. You do have to be vested in wanting to work on your diabetes. Yes, you still have to do a finger stick when you're on insulin pump therapy. And one of the other cons is that there is no long-acting insulin when you are on insulin pump therapy. That is a con because that long-acting insulin is a little bit of a protectant to keep you from going into diabetes ketoacidosis, particularly for those patients with type 1 diabetes. On the flip side, one of the pros is that instead of giving a dose of Lantus or Levemir, where it's distributed pretty constantly over 24 hours, one of the pros to insulin pump therapy is that you can actually titrate that delivery over the daytime hours. So daytime and nighttime hours for that matter. So if you know that you rise, you have the dawn phenomenon, your numbers are rising around 4 or 5 a.m. with insulin pump therapy, you can actually customize with your healthcare team the delivery so you get slightly more insulin prior to that rise to prevent that. And it's very nice with insulin pump therapy that you can actually, you know, suspend delivery for instances like, oh, maybe shoveling snow. You know, we're in December, it's coming. You can suspend delivery if you're out there and working excessively shoveling snow and you expect to have a low blood sugar due to the extreme exercise. So there's a lot of benefits to this. If this is something that you're interested in, talk to your healthcare team and they will help guide you to a system that will work best for you if that's what you're interested in. And here's a picture of the pumps that are available. The top left-hand corner is the Medtronic pump. Remember back on our discussion of CGMs, this pump does have a continuous glucose monitor that can be utilized along with this pump if you wish. You can use it with or without that device. The top right-hand corner is the tandem insulin pump. And this picture is showing it in combination with the Dexcom G6 continuous glucose monitor. And then at the bottom of the screen is the third insulin pump, and that is the Omnipod. So if you think about the top two pumps, they're both tubed pumps, meaning there is a small tube that's connected to a little catheter that goes underneath your skin and is changed out roughly every 3 days. And there's a tube that kind of leads to your pump. Your pump can be worn on your waistband, thrown in your pocket, worn discreetly in other ways. But the bottom pump is unique in that it is a tubeless pump. That is the Omnipod insulin pump. And they are also working on an affiliation with a continuous glucose monitoring device as well. Again, all of these pumps can be used just as insulin delivery or in conjunction with continuous glucose monitors. And the one differentiator on these pumps, again, just to reinforce, is that the Omnipod is a tubeless pump. And every 3 days, that entire thing is changed off of your skin that you'll see on that patient's arm. And is there more?
I think this is our last one. And
that's about it in a nutshell. Thank you for your time.
thank you.
Thank you. I have a question for Celeste right away.
Uh-oh.
No, I want to get, and Dr. Hundal probably could answer too. So when I'm teaching about meters and we talk about if you get a weird number, checking again, but I always tell them to use the control solution that's in the box, and probably 90% of the time I hear, I don't know what that is, and it wasn't in my box.
Yes.
Do they not provide it anymore, or are the patients just missing it? Because they swear they don't have it and they've never seen it before.
The last meter that my son received did not have control solution. And I feel that, coming from the peds world, that is something that we really, really stressed, was to always use control solution with a new bottle of test strips. And the adult world, I feel like it's one of those things that has gone aside. Dr. Hundal, do you recommend your patients use control solution?
Usually with the new meters, that's what they are saying, is that those ones don't need calibration. Okay. So that's why you are not getting the control solution. But usually they are still available. Sometimes you can go to the pharmacy and get the control solution for it, in case some people have asked them to get the control solution if they're getting very different readings. Mm-hmm. But that's the reason why the new meters are much more accurate. And that's why they are not advocating that they need calibration.
Well, thank you for that. I didn't even know that.
And the other thing is very important for patients to understand. They always keep on saying, oh, if I check from this finger or this finger, they keep on using their partner's glucose meter too. And they will call, multiple calls we get is, oh, I checked from here, there's like 15 points lower, 20 points lower. I checked 5 minutes later, it was this. They get more confused and start thinking that the meters are not working. You have to remember there's always like 10 to 15% variation in the glucose meter reading. And the higher the reading is, the more variation there'll be. So if, for example, if it's 100, it can be either 90 to 110. That's within that standard deviation. If it's 200, it can be between 180 and 220. If you go to 300, then it can be even longer, more variation. So usually we tell the people is like, don't to get too much focused on, like, it should not be one is 50, another one is 150. That's a very big difference. But in general, we usually educate patients, okay, just you can check 1 or 2 times, but don't get focused. Also look for your symptoms too. If the blood sugar it's reading for some reason is giving 50 and they feel completely fine, they don't have hypoglycemic awareness, then there is some problem with the meter. But again, you have to just educate. That's the most common question you get from the patient is, I use my wife, I use my husband's meter. They always give good, different readings. My meter is not working. So
I'm really glad that you brought that up, and I had meant to kind of address that as well. Yeah, and even if you're using the same meter and using different fingers, you'll never get the same results. Yeah, right. Yep, that's a very good point.
That's true. I'm glad you guys.
Dr. Hundal, are you seeing more utilization of the remote monitoring devices now with the telemedicine?
Yeah, we are doing the more like all these glucose sensors. They all have their own cloud, so they're the people, younger people, individuals. They are now downloading all those readings. So we just have to get their consent. So we usually send them an email. Once they have given us the consent, then usually we can download their sensors without the patients being in our office. But we usually tell them that it's not like they don't start thinking like this is a EKG heart monitor that somebody's sitting there and I'm constantly looking at their blood sugars. So we usually tell them, if you are having problems, just call us, send us an email. Oh, I'm having some issues. Can someone look at my readings? Then we can download it and then can go back and talk to the patient. So we usually are telling them now all the apps they should try to download on their cell phone. If they don't download it, then it's because some of these glucose sensors have reader, but those ones don't download to the cloud. So those ones we cannot do anything. They have to physically bring that reader to the office so we can download and look at the graphs. But if they have their app on the smartphones, then it can be, they don't have to be in the office. We can download from wherever they are.
Well, and I think there's an issue too. Some of my people, like they want the G6, but their phone is too old. Like you have to have a certain type of phone for different.
Right.
Is that only Dexcom, or they all have different?
No, the other one too. For the Freestyle Libre is the same thing. Yeah.
Okay.
Now they have the Freestyle Libre 2 and 3 will also be coming. So the Libre 2 has alarms in it. The original Libre did not have any alarms in it. So Libre 2, still they are making an app for the smartphones. So at this time, if you order Libre 2, they have to get the reader. So they cannot download on the smartphone. So, but their app for the Libre 2 will be shortly coming. They were saying maybe in January or December, by end of December. So once that comes, then the Libre 2 sensor can also be downloaded to the smartphone, and then we can download in the office.
Which is so much easier in this weird time that we live in.
Right. I mean, they just shoot us an email, we look at the readings, discuss with them. It's so convenient.
Well, I don't know if there are any other questions, but I do want to thank both of you, well, all 4 of you actually. So for the late night live session, I do see a lot of feedbacks from our patients and different people that we talk to. Hopefully these are helping everyone, especially for these difficult times. I don't know if you guys can see, but Buddy is like, okay, so is it over yet? So I know your dogs are probably waiting too. But thank you so much again for being with us, and then we'll see you, I believe, in 2 weeks, right, Amy?
Oh, January. So this was our only one for December, but we'll be back the second Tuesday of January, and we have a whole new list of topics for next year.
And second Wednesday.
Oh, sorry, I said Tuesday, didn't I? I'm sorry. I don't know what I was thinking. Wednesday. I apologize. I'm a day behind, apparently. So yes, the second and the fourth Wednesdays of every month. So we'll be back in January.
On Fridays, we have our 12 noon sessions from United Medical ACO for updates from COVID and other stuff with the pandemic. If anyone is interested, they can also follow us on the Friday event. But until then we'll see you next year then. Thank you so much.
All right, thank you.
Thank you.
Thank you.
Thank